the compliance with guidelines, as well as the clinical practices of the peers and the general practitioners. Clinicians were asked to share considerations and or limitations to determine, as well as in using second-generation antihistamines. All right, so this is all in the Asia-Pacific region. So what are the specialists involved? Well, the first group were ENT doctors. 80% of them follow the ARIA guidelines in the Asia-Pacific region, of which one tailors treatment according to the patient needs. In the other 40%, they prefer to follow the country guidelines, such as the clinical guidelines of allergic rhinitis in Thailand. All right, so it depends on the local practice and adherence. As far as the skin doctors are concerned, they all tend to follow the EACI, Galen, or the international guidelines. Maybe the internists a little bit more into the follow the global accepted guidelines, whereas the surgeons at ENT has a little bit more leeway when it comes to following their own guidelines or their own patient pool. I don't know what's the difference. The non-compliance due to lacking awareness of dosage adjustment or individual preferences for specific antihistamine combinations. All right. So this is what the conclusion of the skin doctors came up to. Now, how about general practitioners? There's a differential. There can be full or partial adherence to guidelines, but some may not be aware of even the guidelines' existence. All right. So yes, general practitioners are extremely busy people. We see they see a lot of patients. Maybe that is the reason, or maybe they don't have a chance to participate in enough CMEs in this Asia-Pacific region. We don't know. There is a lack of local guidelines and the fear of prescribing or using steroids, which contribute to the non-adherence. All right. Steroids, when used in the correct situation, correct condition, yes, very helpful. But sometimes when used wrongly, yes, that's when we see the disasters. So being unfamiliar with steroids may be one of the key contributing factors for the treatment of this allergic rhinitis urticaria for the entire spectrum of management. And of course, first generation antihistamines are still being used by a lot of general practitioners out there to treat all these common allergic symptoms. So there's a series of unmet needs and consideration in treating allergic rhinitis and urticaria. And what are the unmet needs? Inadequate control of symptoms, lack of long-term, long-acting, non-sedative drugs, as well as single drug. There's no single drug that's with all the preferred features of an antihistamine. And what do we need to consider? The patient profile, right? The patient economic background, the kind of work that the patient does, consideration of taking antihistamines by special populations. All right, so certain conditions that make the patient unsuitable to take certain kind of medication. All these have to be taken into account. So there is a suggested treatment algorithm based on the ARIA guidelines, and you look at this busy slide. Pretty much, you look at the diagnosis, the age of the patients, the presence of any concomitant diseases, whether there's a hepatic or renal impairment, as well as the patients will require high level of concentration in their workplace, the kind of work that they do. And really what you see is that across the board, actually the simplest approach is you just look at the first line right across here. Everyone is Biloxi. All right. So there is something out there that requires you to be, well, I wouldn't use the word brainless, but don't even need to think much. Pretty much everyone out there can use, which is safe and suitable and effective. All right, you can see Biloxi across the whole spectrum of different needs. Okay. The suggested treatment algorithm based on EACI, Galen, EDF or WAO guidelines, suggested treatment algorithm for urticaria. So early on was allergic rhinitis. I think you come to a similar conclusion. With the vertical axis, you see all these different criteria. But again, you're going to see same. You come to the same conclusion where Biloxi is one drug that you can use across the spectrum of different illnesses, different patients, different backgrounds. So Biloxi is the preferred antihistamine. It lacks cardiac side effects. very safe for the elderly, non-sedative, easy to use, once a day dosage, and very high efficacy. All right. So, and those requiring a lot of concentration and work, meaning you cannot afford feeling sleepy or even sleep short in your work, yes, Biloxin is the answer. Additional attributes of Biloxin: it has the highest number of desired features for a modern antihistamine according to international ARIA guidelines. One of the lowest cerebral histamine H1 receptors occupancies. All right, less penetration and therefore less sedative. It's probably the least sedative antihistamine out there. And its benefit to risk ratio is optimal and meets condition for safety in drivers requiring antihistamines. All right. So when we talk about drivers, it's think about really the ones that spend a lot of time on the road, the Grab drivers. We are talking about the taxi drivers, trucks. All this, you can get exposed. Sedation is going to cause you to be dangerous on the road, and safety not only for the drivers themselves, for the occupants, as well as for the other rest of the drivers on the road. So the conclusion of this study is compliance with guideline is generally present among skin doctors, allergologists, and ENT specialists, but is lower among general practitioners. Guideline updates may be useful to reflect the different patient profiles and varying symptoms of allergic rhinitis and urticaria. Unmet needs include an inadequate symptom control, long-acting non-sedative drugs, and drug with all preferred antihistamine features. Lastly, Biloxin, as we all have seen, the conclusion was, is the preferred non-sedative product properties. So once daily dosing, it's high efficacy, and its lack of cardiac side effects and safety among the elderly patients, which is extremely, extremely important. Very easy to use for all your patients, right? We can say all your patients. All right, so that brings me to the end of my talk in terms of the study. Now I want to share with everyone, since January, everyone's talking about the COVID-19 and stuff, but a lot of us, life still goes on. We still see a lot of patients with upper respiratory tract infection and stuff. I'm just going to pick up two of my patients that I've seen since January until 2 weeks ago as part of this upper respiratory tract problem. All right. This one just happened. This patient presented to me just before Chinese New Year. All right. 10-year-old boy, sudden left eye swelling for 4 days. Started with fever, mild, upper eyelid swelling on the left side. Now, this picture you are looking at, this is on presentation to me, and the eye swelling has been progressive over the last 4 to 7 days. Saw GP twice. Now, and because of increased pain, kept on going back to the GP as well, as finally ending up with the emergency department. He was at first treated as allergy, right? Sometimes you get all this eye allergy, itchiness, pain, and swelling. But the most profound symptom that he had was the intense pain, which is disproportionate to his symptoms. All right, he had a bit of a low-grade fever as well, and really absolutely minimal nasal symptoms. All right, all the eye. So actually at A&E, he was referred to the eye doctor, and after admission at the hospital with low-grade fever for about a week or so, finally we managed to diagnose and got to me. Okay, so children usually don't exaggerate their pain. So if a child complains about pain, we really have to take it at their face value, and we really cannot discount them. All right. So children, to me, are probably the most trustworthy patients out there. Now, so the other thing is, if we have bothered to look at the eye, not only just the outside, if you examine the eye, well, is there involvement of the orbit? So you look at this child. Well, he was very miserable. All right. So the first time I saw him, he didn't even want to, because he was having fever, he was having a lot of pain. He wasn't interested in talking too much. But anyway, after much coaxing, now you lift up the left eyelid, and I asked him to gaze to the left lateral side. You find that the left eye is not moving. All right, you see the the eyeball is not moved as much lateral compared to the right side. So there is